I'd like to welcome you all to the first talk of a 4-talk series that will be taking place here at the library under the guise of the brain boom, how neuroscience is changing how we understand ourselves. My name is Jackie Sullivan. I'm an assistant professor in the philosophy department at Western University, and I'm also a member of the Rotman Institute of Philosophy. And it's my pleasure tonight to introduce Dr. Catherine Stinson, who's going to be our speaker this evening. Dr. Stinson has a master's degree in computer science from the University of Toronto and a PhD in history and philosophy of science from the University of Pittsburgh. She's currently a postdoctoral fellow in philosophy of neuroscience at the Rotman Institute of Philosophy at Western. And her research spans the areas of philosophy of psychology, philosophy of neuroscience, philosophy of computational science, and philosophy of psychiatry. In addition to conducting research during her time at Western, she's been in charge of a reading group in philosophy of neuroscience that brings together faculty and graduate students from the Rotman Institute and Western's Brain and Mind Institute to discuss hot topics in philosophy of neuroscience. And it's been a real pleasure having Catherine at the Rotman Institute because she has a unique talent for honing in on really interesting philosophical questions and offering a novel and fresh perspective in response to them. Her talk this evening is a fine example of what really sets her philosophical work apart. In fact, it is based in part on a paper that is forthcoming in Synthes, which is one of the top journals in her field. The title of her talk this evening is The Body and Mental Illness. Please join me in extending a warm welcome to Dr. Stinson.
So thank you for coming, and thank you, Jackie, for that very nice introduction. So mental illness or mental health, that gives the strong impression that this has something to do with the mind and not the body. And the mind and the body are supposed to be these two very different things, different fundamental substances, things that don't really interact with each other. So what I'm going to be talking about is first how mental and physical are treated as these very different things. And this is a traditional view in philosophy, but also in psychiatry, it creeps into the way people think about mental illness. And I think it's not really justified that we treat them as these two very separate kinds of things, or that we treat mental health and somatic health of the rest of the body, as these two very different things. So one point I want to make is that mental illness is just as real and just as embodied, just as experienced in the body as any other kind of health or illness. And that often there are important physical symptoms in mental illness, and that these are largely ignored and overlooked. And the patients in mental health contexts are often treated like they're not fully competent, and so they're not really listened to by their doctors, they're not listened to by society in general. They're treated as though they don't really know what's going on in their own disorder or their own condition. And that's something that I think also needs to be changed, because that does harm to these people, and it also does harm in terms of the understanding of the disorder or the disease, because these people are in a unique position to really understand what the experience is like that they are experiencing. So we should be listening to what they say in order to understand it better. Okay, so the examples I'm going to focus on are autism and anorexia nervosa. So my point is something a little more complex than just that, general health, eating well, getting enough sleep, that, these aspects of the body can have an influence on the mind. So I take it that we all know that these things can affect our mental health in some ways. So being generally healthy can make you're more mentally healthy to some extent. So I take that as understood by everyone in the room, hopefully. That's not really what I'm talking about. I'm talking about something a little more complex than that. So here's just the general picture of how philosophy for millennia has seen the mind and the body as not really related at all. These two very separate things that work according to very different rules, that are studied in very different ways. And maybe they sort of touch each other, but we're not really sure whether they can interact with each other or how exactly that happens. And this mind-body problem, how do these two things interact, is seen as one of the biggest unsolved problems in philosophy. So I think that this is the wrong picture to have when we're talking about mental illness or mental health. But it's been a very influential idea, and maybe a little bit too influential. So we think of the body as being sort of like a machine that can be repaired when something goes wrong, or like something like a biological machine that we can do surgery on to fix, or like some kind of a chemical system that might get out of balance, and then we can use drugs to try to put it back into balance. So these are the kind of interventions that we use in somatic medicine to deal with problems of the body. And we have a very different view of how the mind works and how we can change people's minds. To change someone's mind, you reason with them, you talk to them. And so talk therapy makes a lot of sense as a method for psychiatry. And sometimes it works well, sometimes it doesn't. When it doesn't work well, people just sort of don't know what else to do. And historically, and still to a fairly alarming extent now, the next option is incarceration. And so this is a picture from 2013, Cages for Mental Health Group Therapy. And this is in the US, so maybe we can pat ourselves on the back that this isn't a picture here, but it's not very different here either. So I think we need to do better than this. And I think we can do better than this. So here's just a kind of a cartoon picture of how a lot of people view mental illness. So the text is the sorts of things that people say to people who are having trouble with their mental health, but it's put on pictures where people are having a physical health problem just to show what a different attitude people have. So I get that you have food poisoning and all, but you have to at least make an effort. Or with this person whose hand has been chopped off, you just need to change your frame of mind, then you'll feel better. And it's obvious in these cases this is a really inappropriate response to this problem. And to people who've experienced mental health problems personally, those kind of responses to their problems feel just as inappropriate. But people who haven't dealt with mental illness problems personally often don't really understand this and don't understand that trying harder or thinking different thoughts or looking on the bright side doesn't really change the situation, that mental health problems are just as real and just as outside of the person's control as any other kind of health problem. Okay, so people are told to try to act normal or just eat something or try to be reasonable, but they can't because their bodies need to move differently, or eating feels awful, or their fears that seem to other people irrational feel rational to them. So it's not just like a mood swing or like a false belief, it's something that's more sort of embodied than that. So here's another little cartoon that gets at a similar idea. So because people don't always understand that mental health issues are just as real as physical health issues, they have less sympathy for them. So we've got Joey needs a new kidney and lots of money put in the can. Please help, Jamie needs psychiatric care. We're desperate, a few coins in the can. And the fact that there is less sympathy means that, so when someone gets a diagnosis of schizophrenia in their early 20s, what happens fairly often is that gradually they get shunned by their friends and family, and they're treated as suspicious by strangers or by the police. They get fired from their jobs for doing things that are really just coping mechanisms, and are generally discriminated against. And of course, social isolation and the poverty that might come along with this kind of discrimination doesn't make matters worse. It doesn't make matters better, and in fact might make their symptoms more difficult to deal with. So I think it's important to note that the majority of psychiatric disorders do have measurable physical markers. We can do tests and see, yeah, there's a difference between this person's brain or this person's body than a neurotypical person. So just a couple of examples. In schizophrenia, there are differences in the sizes of the brain ventricles. And there are differences in responses to tactile stimulation, to touch. And there are lots of other examples like that for other disorders. So the difference isn't whether it's possible to find physical signs or symptoms like those. The problem is that this physical side, which does exist, is often overlooked. And so I'm saying that this is the problem. This is just a part of the problem. So this is something that if we fix this, I think that might help the situation, but I'm not trying to claim that this is sort of the fix for the problems in psychiatry. Probably there are lots of other things that need to also be done. So this is just one suggestion that maybe needs to be accompanied by lots of others. Okay, so what can we do about this? This is the picture that's often assumed, and assuming this picture, I think, is at least partly to blame for these problems. And one of the main points I want to make is that we should see it a little bit more like this. So the mind and the body, they aren't two completely separate things, but they largely overlap, and it's hard to tell, where this overlap is exactly and where the boundary is, and that they interact with each other in many ways. So what you might consider mind affects the body, and what you might consider the body affects the mind, and so on. And these connections often go underappreciated because we're so used to thinking of this picture. So it looks simple up here. You just sort of squish the circles closer together and you add a couple of arrows, but actually making this happen is a little bit more complicated. So I want to try to be really specific about what exactly I mean here, because I think this can be confused with a couple of other views that might seem similar on the surface. So one approach that I'm not endorsing is the idea that we can just treat the mind as a part of the body. So just treat the mind as being the same thing as the brain, and the brain is part of the body. And then we can just apply our medical model that we use on the rest of the body to the brain, and then that's all the mind is, so that should solve the problem. So I think there are some good things about this approach, but also some things to be very worried about. So this is not really what I'm endorsing. So just applying these methods that we use to the body and thinking that we're sort of done. And one of the reasons for being a little skeptical of this is the history of this kind of approach. So doing brain surgery, giving people drugs for mental health problems has a history that includes frontal lobotomy, just reaming around with an ice pick through the eye socket. That never had a good result. Electroshock therapy has some legitimate uses, but it was overused and abused for many years. And these days, people are being prescribed psychoactive drugs, sometimes off-label, so not for the purpose that it was developed for and not for the purpose that it was tested for, and sometimes after a 5-minute interview. And there's nothing wrong with neurosurgery. There's nothing wrong with using drugs for mental health issues, but we need to be cautious and a little bit more careful about how we do it. So I don't want to say that the medical approach is all bad, and I'm putting a big red line through it, but it's not all bad. So I know people who have benefited from neurosurgery. A childhood friend who had intractable epilepsy has had her life changed, and she wouldn't have been able to have a job or have a family or ever drive a car if she hadn't had neurosurgery. So that has benefited her life, and and not just hers, lots of other people's. And I also have friends who probably wouldn't be alive if it weren't for the psychiatric drugs that they're taking that manage their symptoms reasonably well. So the medical approach is not all bad. But as I said, we need to be cautious about it. So because the symptoms often show up in terms of behavior, it's a little too easy to treat antisocial behavior or merely inconvenient behaviors as pathological. And there's also a history of psychiatry doing this. So one case that has sort of changed within the last 20 years or so is homosexuality, which until about 20 years ago was listed as a psychiatric disorder. and then it wasn't anymore, and I think we've all seen that people's attitudes towards homosexuality have been gradually changing since then, and whereas a few decades ago most people would have seen it as a behavior that we can't support and must be changed, and people looked for cures and looked for treatments, and now a lot of people, hopefully most people, look at homosexual behavior as just part of normal variation, and not everyone does it. Some people do, but we don't have to really care one way or the other. Just as left-handedness used to be seen as a really bad thing, and people tried to cure it and change it, and now we don't anymore. You see someone writing with their left hand, you might notice, oh, that person's left-handed, but you don't attach a judgment to it. And homosexuality arguably is moving in that direction as well. Okay, and there are other examples like that are in the history of psychiatry. Another approach that I'm not endorsing goes in the opposite direction of putting all of physical illness within the mental realm. So thinking that, like this image says, that all problems are illusions of the mind. So there's nothing wrong with yoga, there's nothing wrong with positive thinking. Yoga can probably help with your posture and with your core strength and with your flexibility and maybe with your focus and concentration and stress relief. So nothing wrong with yoga, but it can't cure type 1 diabetes. And positive thinking can't cure cancer. Positive thinking can't even cure gingivitis. So it's not a cure-all. Being an optimist can probably make you a happier person, but it doesn't do much more than that. So I don't think we can just ignore the seriousness of symptoms of mental illness, so putting a cross over that one too, and just sort of pretend that they aren't there or hope that they'll go away if we just try to be more accepting. I think that's not really going to work. There is really a problem that needs to be dealt with. So positive thinking isn't enough. So I'm not a supporter of anti-psychiatry movements, but that's not to say that psychiatry doesn't have its problems. So it certainly does. And if you are into the sort of yoga type solutions to mental illness, there's some flyers here that someone dropped off earlier for a group that you might want to join. Okay. I said I would advertise the flyers, and I have. Okay. So, what am I suggesting? How do we dissolve this mind-body dichotomy, and what kind of benefits will that do? So, a few specific ways that we can do that. Acknowledge that mental distress is just as real and just as unwillingly experienced as any other kind of more visible physical illness or symptom or lesion. Second, that we should recognize that first-person accounts, so what the people who are diagnosed with these disorders say about how they experience the disorder. We should treat these as a valuable source of evidence about the disorder instead of just discounting them as irrational or the ravings of a lunatic. We should take them seriously. They know better than anyone else does what it's like to experience what they're experiencing. And often that's not done, even in regular medical contexts. So if someone goes into an ER or into a doctor's office and their chart says that they have a psychotic disorder, and they go in and complaining of the symptoms of appendicitis, then they don't get treated the same way that someone else explaining the same symptoms does. They don't get rushed into surgery. The triage nurse wonders, are they just delusional? Are they saying this for some other reason? And then they sit in the waiting room and things go awry. And children with autism, autistic children, don't get given anesthetic when they're given needles, when other children are given anesthetic, because there's sort of a prejudice that autistic children don't feel pain or don't feel pain the same way or don't feel as much pain when if you actually study, do autistic children feel pain, you measure their skin response, they do feel pain just as much as other children. But when they go to the dentist, when they get a shot, they're not given anesthetic or not given as much anesthetic. And also, when they try to give reports about what's really going wrong with their disorder, psychiatrists have tended to just not really listen to them. Okay, and 3. In at least some cases, a good approach, an approach that we might want to consider, is accepting atypical behavior as just part of the natural variation of how humans behave. That this often would be an appropriate response to behavior that seems abnormal. And this isn't going to cover all of the symptoms, obviously, but some of the symptoms can be covered by this. So, we used to treat left-handedness, as I mentioned before, as something that needed to be corrected, and now we see it as something just an unremarkable difference. We could treat the hand flapping of someone who's autistic the same way. Oh, that person flaps their hands. So what? Or we could treat someone responding to a voice in their head and seeming to talk to themselves as like, oh, that's someone who talks to themselves. That's someone who has auditory hallucinations. So what? Is these aren't dangerous behaviors. They're like maybe slightly distracting sometimes, but treating them as pathological has serious negative effects on the people who behave this way. And they don't behave this way because they want to. They behave this way because they have to, because that's the way their body works. So one of my suggestions is that we should try to do more of this. And I know that I'm not there yet personally. I still want to cross the street when I see someone acting like they're talking to themselves and having a delusion. I try not to actually cross the street. I try to stick to the path and be understanding, but I think I hope that I can get there, and I think that probably more people can do that too. Okay, so what does this all have to do with the body? So I'll start with the first example I want to go through, which is autism. So first I'll just sort of explain what autism is very briefly. So there's 2 kind of classical pictures of it that were independently described, and then they got kind of lumped together into the same thing. So one is classical autism. So this is describing a person who's usually nonverbal, and they seem closed off in their own little world, and they're usually at least thought to have intellectual deficits. Sometimes it turns out not to be true. And in some cases they have peculiar talent, so they're really, really good at something that most people aren't really, really good at. And the second sort of classical picture of Asperger's is more like antisocial behavior, avoiding eye contact, missing social cues. And these 2 have been sort of combined into one spectrum recently. And in both cases, another typical symptom is repetitive behaviors, so something like rocking on your heels, or flapping your hands, as I mentioned before, or verbal tics, repeating the same syllable over and over again, or humming, or spinning, or jumping. There's a bunch of different types of repetitive behaviors. And the popular theory of what's going on in autism that has persisted for a number of decades now is that autistic people lack theory of mind. So that they lack the ability to realize that other people have something going on in their minds that's different than what's going on in my mind. Other people have thoughts and beliefs and desires that are different than mine. And also the ability to sort of guess in reasonable ways about what this person might be thinking, what that person might be thinking based on the context or whatever other knowledge you have. So the theory is that they're lacking this theory of mind, and that they're lacking empathy, so they can't sort of see the emotions in other people and feel them themselves. And the 2 kinds of tests that are used to supposedly show that this is what has gone wrong in autistic people are these 2 tests here. So on the left, it's called the Sally-Ann test. So Sally, who's on the left, puts her ball in the basket, then she leaves the room. Anne comes along, takes her ball, puts the ball in her own box, and then when Sally comes back in the room, and then this is the question that is sort of the test, you're supposed to say, where will Sally look for her ball? And after about the age of 3, most people can answer this correctly, which is to say that Sally will look in the box. Sorry, Sally will look in the basket, not in the, apparently I have trouble with that. Sally will look in the basket, not in the box, because she doesn't know that Anne moved her ball. So that's supposed to be the right answer. And a lot of people, including a lot of autistic people, have criticized this test as not really showing whether or not you can tell what might be in someone else's mind. It might be testing a bunch of other things. So it might be that it's kind of a complicated verbal test, and if you have trouble with verbal tests, then you might do badly on this. That would be one option. Another option that was described in one of these first-person accounts that we should be taking seriously, I think, is that the person is empathizing so much with Sally that they want her to get the right answer. And so they say, Sally's going to look in the box, because they want Sally to be right. And they know what the right answer is. And so that's not knowing what Sally knows. That's not lacking empathy. That might be having too much empathy for the test. So these might not be the best ways of testing whether someone actually knows that other people have thoughts and can guess what other people's thoughts might be. The test on the right is called the Reading the Mind and the Eyes test. And so this is a test of empathy. Okay, so the top one, we look in his eyes and we want to know whether he's playful, comforting, irritated, or bored. What do people think?
Playful.
Playful? I think playful is supposed to be the right answer. And the middle one, is he terrified, arrogant, upset, or annoyed? Upset. Someone else has a different idea? And the bottom one, joking, flustered, desire, I don't know why it's not desirous, but we'll put that aside. Convinced. Okay, so that's sort of how the test works, and the way the test is scored is they had a bunch of neurotypical people who aren't autistic, look at these and say, which one do you think is right? And then whichever one most people think is right is considered the right answer, which is sort of reasonable unless most people who aren't autistic, just aren't very good at reading emotions through the eyes. That's a possibility. It's possible that people who are autistic are better at reading emotions than neurotypical people. So if they give different answers, it might be because they're better at empathy. And that's actually one of the criticisms that some autistic people have given of the test, that these are actors putting on sort of a show of an emotion. They're not really pictures of people experiencing these emotions. And especially in the bottom one, if you look at it closely, it doesn't really look that much like this person is experiencing desire. It's more like a picture of someone who the person looking at might feel desire towards. It's more of a sort of a come hither look of an attractive woman. And so this is another criticism brought up by autistic people of this test, that something that they find confusing about this test is telling the difference between what the person is, the emotion that the person is trying to act out and trying to project, and the emotion that it looks like they're actually feeling, which sometimes aren't the same when you're looking at an actor who isn't really feeling the thing that they're supposed to be acting like. And so some people have said that when they do these tests, they answer more accurately than neurotypical people, because they can see a little bit more of the way the actor is really feeling, which might be bored in many cases. Okay, so there are some problems with both these tests. Another big problem with the test on the right is that it's just focused on the eyes, and one of the well-known and very common symptoms of autism is not liking to look people in the eye. So there's built into this test this stressful thing, and if you build stress into a psychological test, you've made a really bad psychological test, unless what you're trying to measure is how people react to stress. When people are stressed, they do worse on any kind of task. So the fact that they do worse on this task that we know is stressful for them, it doesn't really show that it's the task itself that they have a problem with, the empathy part of the task. It might be just, I have to look at eyes, so I'm not gonna do very well because I don't like looking at eyes. Okay, so for several decades, this was kind of the standard theory among psychiatrists of what's going wrong in autism. And for decades, people with autism, I'm trying to say autistic people, and I keep saying people with autism, because that's what they prefer to be called. So for decades, autistic people have been reacting against these tests and reacting against this theory of mind theory, saying, no, this isn't what's wrong with me. I have empathy. And I can tell that people are thinking things, and I often can tell a little bit too well what they're thinking, and I can tell what they're thinking even though they're trying to pretend that they're thinking something else. And part of what makes my reactions to people seem antisocial is that I'm responding to the way they're actually feeling instead of the way that they are projecting that they want me to think that they're feeling. So what autistic people overwhelmingly say is wrong is something to do with perceptual, sort of an overload of some kind of perceptual information and maybe too little of other kinds of perceptual information. So fluorescent lights might be really overwhelmingly bright to people, or crowded rooms might be painfully noisy to people, or with some people it might be vestibular stimulation that's sort of out of whack, or it could be interoceptive awareness, so the feeling of the state of your internal organs. So any kind of sense might be either sort of overstimulated or understimulated, and if you look at what autistic people say is wrong with them, they say that these are the problems that they have, and that the reasons why they do these repetitive behaviors, like flapping their hands or rocking or humming, is because that's a way of regulating their sort of out of whack perceptions. So they call this stimming, and they do this as a coping mechanism. If you can flap your hands when you're in class, then you can concentrate better on what the teacher is saying. And then if the teacher tells you quiet hands and you have to put your hands down, then you can't block out all of the other stimulation that you're trying to block out, and then you can't concentrate on what the teacher's saying. So these are the sort of reports that people give there are lots of blogs written by autistic people and videos online of autistic people telling about their experiences, and these are the kinds of things that they say. And there's also, in these sources, lots of reactions against the presumption that they're incompetent to say what it is that is wrong with them. So just the presumption that when they say, no, I don't lack empathy, the reaction by some psychiatrists is, well, really you do lack empathy, just you don't know that you lack empathy because you don't know what empathy is. But they say, no, I do know what empathy is, and here's all kinds of very eloquently written and convincing stories about how I was empathetic at this time or another. And like if you read them, at least I found them just undeniably convincing accounts of people having empathy or people having theory of mind, and finding it really incredibly frustrating that them saying this doesn't seem to mean anything to psychiatrists. So what seems to be most important in autism is not something to do with the mental, it's not this theory of mind, it's something to do with their bodily needs and the way that their body works. And that when they have communication problems, often that's because of these symptoms, or it's because of not being able to move their bodies the way that they need to move them, that makes them unable to communicate. So what can we do about this? And because I've been saying we should listen to first-person accounts, I'm going to read a quote for you from a post called Quiet Hands on a blog called Just Stimming. So Julia writes, "Tara can read my flapping better than my face. You've got one for everything," she says. "And I wish everyone could look at my hands and see, 'I need you to slow down,' or 'This is the best thing ever,' or 'Can I please touch,' or 'I'm so hungry.' But if they see my hands, I'm not safe." "They watch your hands," my sister says. "And you might as well be flipping them off when all you're saying is, 'This menu feels nice.'" And at the end of the post, she writes, "If you grab the hands of a developmentally disabled person, if you teach quiet hands, if you work on eliminating autistic symptoms and self-stimulatory behaviors, you take away our voice. You create this part of this communication problem that is one of the symptoms." And as the same author describes elsewhere, she's physically unable to lift her arms now because of having her hands held down by force as a child, so that's teaching quiet hands. And then reinforcing that prohibition herself in order to pass as neurotypical and not, be abused, be bullied, be beaten up, be made fun of. And she says, the emphasis in education and intervention is to make the child look non-autistic, not to prepare them for a future as an autistic adult, which perhaps should be the emphasis in education and intervention. So I think that this kind of thing, somebody needing to flap their hands in order to concentrate on what they're trying to concentrate on, in order to feel balanced, that's something that we could accept as just part of the natural variation of how humans behave. And it might not be something that we can do just overnight or automatically, but it's something that we can probably get to. And I don't mean that to deny that there is disability in autistic people. There is, but not all of the things that they struggle with are actually the disabilities. A lot of what they struggle with is people's reactions to their symptoms rather than the symptoms themselves. So stigmatizing the differences in their bodies is part of what does harm. And just as sort of an aside, there's a similar movement to destigmatize hearing voices called Intervoice. So they say that they're working across the world to spread positive and hopeful messages about the experience of hearing voices. And this seems really odd, I think, at least it seemed odd to me when I first encountered this. They say in their mission statement, "We understand voices to be real and meaningful, something that's experienced by a significant minority of people, including many who have no problems living with their voices. Our research shows that to hear voices is not the consequence of a diseased brain, but more akin to a variation in human behavior, like being left-handed. It's not so much the voices that are the problem, but the difficulties that some people have in coping with them." And some of those difficulties are things that acceptance isn't going to really do anything about. If the voices are saying something that's frightening or threatening, then that's going to be a problem regardless of how people react to you having that voice. But at least part of the difficulty is had by people reacting to this. So as I think I mentioned earlier, we could try to get to a place where when we see someone talking to themselves and apparently hearing voices, we could just think of that in the same sort of way as we think, oh, that person's left-handed, oh, that person hears voices. Because it isn't, except in sort of sensationalistic TV shows, hearing voices is not actually dangerous in and of itself. Okay, so example 2. Anorexia. So anorexia is obviously something to do with the body. So already there's a lot to do with the body that is completely acknowledged in medicine and in psychiatry. One of its main features is extreme dieting, and it's one of the essential parts of treatment is refeeding. So it already has something to do with the body, but nevertheless, it's often treated as though it's the result of just poor choices or lack of health information. So people hear things like, why don't you just eat? As though just, changing your mind about whether you should eat or not is all you need to do, that it's as simple as that. But the causes of anorexia, they're not, just false beliefs. They're not just making bad choices. So a few basic facts about anorexia. So here I've listed the 3 diagnostic criteria. So to be diagnosed with anorexia nervosa, you need to have all 3 of these things: low weight or calorie restriction, fear or avoidance of gaining weight, and a distorted experience of the body or a distorted emphasis on body weight. And I've got this third one bolded because this one is really underemphasized in treatment and in research. So here I've got a list of the common treatments. So everyone with anorexia who goes into a clinic gets refeeding therapy. And this is more complicated than it seems. So when you're near starvation, you can't just start eating because you get gastrointestinal problems, you get constipated, you get pain. So it needs to be done really carefully. And there can also be heart complications if you start refeeding too quickly. So refeeding is something that's more complicated than it seems. And often they also get nutritional counseling, even though, as far as I can tell, there's no evidence that people with anorexia have any sort of false beliefs about how much you need to eat in order to stay healthy. It's not that they don't know what a healthy diet is. And the next most common kind of therapy is cognitive behavioral therapy. So this targets habits, changing habits around eating, changing habits around checking your weight or checking your body, and trying to face fears. So this is useful for the first 2 criteria. So far, nothing really touches this third criterion at all. And it's only really very rarely that there's any attempt even or research at all on treatments that would try to do something about the body image part of the problem, about just feeling as though your body is a completely different size than it actually is. And the fact that the relapse rate is over 60% suggests that maybe there's something missing in the treatment of anorexia nervosa. And maybe the fact that this, one of 3 diagnostic criteria is basically not treated at all, maybe that's part of this problem. In research on anorexia nervosa, you see the same thing. So just as a very rough estimate of where research efforts go, I did a search for anorexia nervosa on a sort of a repository of scientific and medical papers, and looked at what the top 50 hits were. 23 of them had to do with sort of biological stuff, neural genetic factors, muscle mass, blood chemistry, stuff like that. 20 of them had to do with emotional and cognitive topics, so how people's attention span is in anorexia and what kind of emotional reactions they have, things like that. 5 papers were about assessment, so tests for assessing symptoms or assessing kind of different kinds of treatment options, how well they work. And only 2 out of 50 dealt with perception of touch and body representation, which are sort of hitting on this third criterion. So that's 4% for 33% of the diagnostic criteria. So it's under-researched. And also, if you look at the way that eating disorders are classified, you see the same kind of lack of attention to this. So anorexia has been classified as an eating or feeding disorder since the beginning of the American Psychiatric Association's diagnostic and statistical manuals, which they use for diagnosing mental disorders. So in the last 2 editions, so that's DSM-4-TR and DSM-5, so the work groups who decided how should we change the diagnostic criteria, how should we change the way that psychiatrists deal with this, they talked about a lot of things internal to this eating disorders category, But they didn't really talk about whether anorexia is actually an eating disorder, whether eating is really the main problem at all. So they talked about whether binge eating disorder should be added as an eating disorder, decided it should be, and they changed the frequency of binging episodes in bulimia, and there used to be a fourth criterion for anorexia, which is that you had to not be menstruating if you were of the right age where you might be. And even though for decades people knew that this wasn't really predictive of anything important to do with the disorder, it stayed in there until very recently. That's another story. So they never questioned, well, is it an eating disorder in the first place? And that was sort of the thing that I went looking for when I went looking at these documents, and they just didn't talk about that at all. But there are really high comorbidities. People who are anorexic also often have another disorder or several other disorders. They often have anxiety disorders and personality disorders and depression, and like there's a long list of things that they have, including body dysmorphic disorder. And another thing that isn't really mentioned is, well, maybe it's a body perception disorder and not an eating disorder. Maybe eating is kind of tangential to what's really going on. And that's what I just mentioned, that maybe eating is tangential. That's what I talk about in this paper that Jackie mentioned at the beginning, that hopefully will be published soon. So some reasons for thinking that maybe this is plausible. So in some research about the comorbidity of body dysmorphic disorder and anorexia, like 30% of people with body dysmorphic disorder also have anorexia. The researchers conclude that a disturbance in body image may be the essential pathology of both BDD and eating disorders. In another study, interoceptive deficit, so that's whether you can sense the state of your body. So that includes whether you can tell whether your heart beating is fast or slow, and whether you can tell whether your blood pressure has gone up, and whether you can tell whether you're hungry, and all these sort of internal sensations. Interoceptive deficit is the best predictor for anorexia. Improvements in interoceptive deficit, so due to therapy, correspond with a decrease in anorexic symptoms at long-term follow-up. Interoceptive deficit in young girls is predictive of illness severity 5 to 10 years later. There are a lot of indications that maybe this perception side of things actually is pretty important. Okay, so if we look at first-person accounts of anorexia, you get a really varied picture. So some people say that what they think is going on with them is about power and control. Other people talk about self-hatred or wanting to disappear. Other people talk about how they're trapped in the self-reinforcing cycle and they'd like to stop, but they just can't get out of it. And some people talk about how they feel disconnected from their body, or they can't tell where the boundaries of their body is. So one story that I read was about someone who used to walk into door frames because she just couldn't tell where her body was. And that made her think, if I'm walking into door frames all the time, I must be really, really fat. But not knowing where your body is could also be an explanation for it. And there's a few quotes here. So these are from interviews in a book about anorexia. A lot of psychiatrists don't know what they're talking about. It shouldn't be looked at on the surface. It shouldn't be looking at as an eating or just an eating problem. And for another person says, it was something to do with not being in my body, transcending my position. And I've just sort of cherry-picked the ones that talk about the body perception issue. There are other people who talk about these other sides of it that I mentioned. And there's lots and lots of information that you can look at on how people with anorexia describe their experiences. So there are websites called anomia sites. It's sort of short for anorexia and bulimia, turned into sort of girls' names, where they talk really candidly to one another about their experiences and about what it's like, and much more candidly than they do to their families or to their friends or to their doctors. And one of the main complaints that psychiatrists who treat anorexia have is that the patients won't be honest with them. The patients lie to them, and the patients, try to hide their food, and they developing the kind of trust with their patient that is needed to be able to actually help them is the biggest struggle that they have. But you can go and look at these much more candid descriptions of the experience if you look at these sites. And these people they're university students, they're professionals working all kinds of jobs. These aren't people who have like major cognitive impairments or any really. They just all feel horrible in their bodies, and restricting their food intake feels better, and eating feels much worse. And one of the main topics that they discuss is how to hide their eating habits from their friends and family, how to hide their weight changes from people they know. And the main problem that they talk about is how they're under constant scrutiny from everyone around them. Everyone's trying to police what they're eating, what they're not eating, what their body looks like. So this constant scrutiny is the thing that they complain about as their main day-to-day problem that they have to deal with. So am I saying that we should accept near starvation as just part of natural variation in humans? No, not really. So people with anorexia need medical help. They have a dangerous problem and need some kind of treatment. But there is a kind of acceptance that would make some kind of a difference, and it's something kind of like this. So this is how to get a bikini body. Put a bikini on your body. And this was the only picture I could find that wasn't of a bunch of women in their underwear, which I didn't really want to show. So scrutinizing the eating habits and the weights of young women, that's something that we can change. That's something that we can stop doing. And that's the fact that there's this constant scrutiny, that's plausibly the main reason why people start dieting, which starts off this self-reinforcing cycle. So we can cut off the most plausible cause by just not doing this scrutinizing. And the scrutiny is also the main problem that people with anorexia complain about when they're talking to each other candidly about their experience. That's the thing that bothers them, is that they have to keep on hiding what they're eating. So one thing that we could do is just let women have any kind of body they want to have, or any kind of body that they happen to have, and not think that it's any of our business. We could let women eat whatever they want to eat and not eat if they don't want to eat, and not think that it's any of our business. And that maybe we should listen to them when they're saying that this is what would help them. So, in conclusion, I think we should reject a strict mind-body dichotomy, at least in this context. In other parts of philosophy, it might be something useful, but that's not what I'm talking about today. So having this strict mind-body dichotomy, them being two very different things, it leads to mental symptoms not being seen as sort of having the same status as physical symptoms. It leads to first-person accounts being seen as not really competent. It leads to behavioral differences being seen as pathological. And if we dissolve the dichotomy, that could lead to recognition of the non-cognitive symptoms of some of these disorders, which might be important ones to look more closely at, to do more research on, to try to treat. It leads to finding valuable evidence about these disorders from first-person accounts. It leads to the ability to accept some of these differences as not pathological, and focus on the ones that actually are real problems. And maybe it could lead to better outcomes. Thank you. Yeah, if anyone has any questions or if you know more about this than I do and have an experience to share, I'd love to hear it.
No, I do not know more than you. I am not a proponent of the ACT or Scientology or anything that thinks that they can cure all your illnesses through the mind. But do we not already have quite a body of evidence that, for example, exercise can create a lot of endorphins, which can better your health, visualization, art therapy, even some people, lighting, not getting enough blue light apparently gives them depression. So are there not a lot of specifically physical things that can affect and help in non-extreme cases?
Sure. So for depression in particular, exercise is supposed to be the most effective therapy. And in other cases, art therapy probably is effective. But I mean, I'm not saying that all therapies have to be physical ones. Art therapy seems like it is a physical therapy in a way, and maybe art therapy actually targets the symptom that needs to be targeted to make an improvement. So
I mean, as opposed to taking medications.
Sure. And I put a big X through the just using medication and surgery as our sort of model of how to treat mental illness. So certainly there are lots of other like just life skills or the things that you mentioned that can also help.
So shouldn't the doctors be going through as many of those as possible before they're handing out the pills? Because I've heard of quite a few.
I think so.
Yeah.
Yeah, I mean, this is one of the reasons for not jumping without a lot of caution into these sort of medical model types of reactions. Yeah.
I think it's a very, I spent my career as an educator, and I found it interesting sometimes that there was the interaction that we had, so I was working with children and young teens, is that we would kind of build a rapport, an understanding of what some of our young people were experiencing, and there was this kind of ceiling in terms of a medical model, because I mean sometimes we'd say, well, we're noticing these, the kids are saying something, and then I think really refers to kind of research that you were doing, that the medical model said it was this, even though what we were observing and experiencing and with the children was different than what that medical, and especially when you, as you said, when you get into the DSM and the categories and that kind of thing. So I think there's this sort of disconnect sometimes between the medical model and what's actually happening within agencies that work with people.
Yeah, that's really interesting. And I think what a lot of teachers would probably say is that if you pay more attention to problems at home or that sort of thing, that you're going to find more of the causes of behavior that is
absolutely
causing a problem in school than if you look anywhere else.
Yeah.
Mm-hmm.
I'm sorry I was late, so you may have missed this, but when you started talking about the interoceptive deficit, I found that fascinating in relation to autism as well, because it seemed to be connected to a way of understanding the body in its context and how it was responding to things. And I wonder what you think about mindfulness, meditation, and the groundswell of attention towards mindfulness as sometimes either a strengthening device or a coping mechanism or a way to counter that lack of connection between what you feel in the body and what's going on psychologically, or even a way to cope with the context.
I don't know anything about that really, but it might be effective. Yeah, I don't really know.
I guess why I'm asking is because mindfulness itself seems to be co-opted now by the language of neurobiology, and it starts to be also a medical head separated from the brain or head separated from the body issue. And I just wonder if you thought about that or come across any literature.
Yeah, I haven't looked into that at all really, and I also haven't really looked into interoception in autism, but I think that that's one of the senses that can be either over or understimulated. So Yeah. But the relationship to that and mindfulness, I really have no idea.
Just following up on what the earlier, the question you had, or the comment you had, it made me think, when you're talking about, when you were saying we during this presentation, I didn't really think a lot about it, but who exactly do you mean by we? And the reason I bring it up is because as a parent, I had one of my children in the school system. We were asked to put them through a series of tests to sort of label them and put them in a box, which turned out all to be nothing. However, this is definitely a child who sees things differently and experiences things differently than what you might call, a regular perception of things and people. So I wondered, when you said we, do you mean sort of each of us individually has, like, what can we do with this now, with this sort of idea that you presented us?
I actually tried not to say we ever, but I guess I must have slipped up. Yeah, so I guess maybe when I said we was about how we can stop seeing certain things
Right.
as pathological.
Yeah.
And autistic people also sort of police one another and don't want other autistic people to show their symptoms sometimes, because then they'll be associated with that, and that will stigmatize them by extension. So we could include everyone in that we.
Right. Sorry. So I guess what I was saying is, this is really, I found this very, very, very good, very interesting. But I'm wondering, I was thinking more of an authority kind of approach. So if everyone in this room were like, oh yeah, that we're completely in agreement, that makes sense, and we can start doing some of those things that you suggested, where does that go? Like, how does that change things generally?
Right. So how do we move from just
How do
this
we
group
impact?
of people
Yes, exactly.
changing things? This video might be put on the internet. Yeah, that's a good question. And then in the paper that I wrote that was specifically about anorexia and not about autism, I was suggesting changes that could be made to the DSM, which was that instead of only categorizing each disorder under one heading or in one chapter, that they could be categorized under multiple chapters, so that anorexia could be an eating disorder and an anxiety disorder and a body perception disorder and so on.
Mm-hmm.
So that's like a small measure, but it's something that I think could be done and would potentially improve how research is done about anorexia, and it could also improve things for a bunch of other disorders that also have high comorbidities with other ones as well.
I think the way children are handling this leads to optimism for the future. In my granddaughter's school, well, in all schools, I guess the children are all mixed together now, children with differences and neurotypicals. And she will talk about a child and she'll describe, the boy that does this with his hands. And that's the only thing she says about him.
Mm-hmm.
They'll have a dance, and that little boy will be up doing his own thing, and they dance around him. It doesn't bother them. Like, they see this sort of acceptance that we're talking about, I see in young people, which is optimistic.
That's great.
I just
And
want to piggyback on that. My first year teaching, I had a flapper, and kids, it's all about inclusion, and he's completely accepted him, and all day long, in the middle of lectures, you just see his arms going, and he'll be looking at things.
And they go to
Cute as
birthday
Betty.
parties back and forth.
Oh, yeah.
There's sociability.
I've noticed this kind of thing when I'm teaching. I teach people who are 15 to 20 years younger than I am, and if the subject of homosexuality comes up, they express things that are very different than what people my age would have said 15 to 20 years earlier, and they say the sorts of things that we sort of wished we believed at the time but didn't quite believe yet. So in that area too, there's I think really change has happened with the younger people. Mm-hmm.
Is there a question about the language that you use to describe people with autism? Like in the psychological community, we try and say, an individual with depression rather than a depressed person, but you mentioned that the autistic population prefers to be called an autistic person rather than a person with autism. And I was just wondering, at least with psychological issues, people don't want to seem like their illness is the only thing that defines them. So I'm just wondering, do you know why autistic people prefer to be fully embraced in that diagnosis?
Yeah, so I can't speak for autistic people on this, obviously, and I don't know what the majority opinion is, but the explanations of that I've seen are along the lines of if you want to put a person first approach, a person with autism, then that's sort of playing into the idea that there's something wrong with being an autistic person, that it's like something that needs to be cured, and that really you're a person first, but you also have this other kind of unfortunate other category that you belong to. And they instead want to sort of own their autism and see that as not just a bad thing about themselves, but that there's also good things about it, and that it's so much a part of who they are that they want to put that first.
But you don't say a person who is smart. You say a smart person. You don't say a person who is autistic. I can see the difference.
Mm-hmm.
But we also see with physical illnesses, like to say a person with cancer, not a cancerless person.
Mm-hmm. Yeah, but there are.
It's contributing to the stigma of like saying, why not, if we want to equate physical illness with mental illness, there's that debate of saying, well, if someone has depression, are they a depressed person, or do they just have depression, and that's a small part of who they are.
So what I'm trying to do is follow what the people in this community want to be called out of respect for them. So that's sort of the bottom line for me. And autistic people, or as maybe you'd prefer to say, people with autism, they're not the only community that does this sort of person second or identity first, or I forget what you call it, option. So deaf people and blind people also prefer to put it that way. Yeah. And I don't know if it contributes to stigma, or, I mean, they think that they want to normalize it. They want it not to be a stigma in the first place to call yourself autistic.
Yeah, I'm just curious if it was the autistic population, like the majority of them, if that's the standard, or if that's just something that a couple of
Yeah, as far as I can tell, that's the standard, but it's, of course, not everyone agrees. Some people prefer to be called a person with autism. Mm-hmm.
I think also when we talk about autism, we know that there is a spectrum, and I get the sense that the population you're referring to, certainly from my experience, having worked with people with autism, and I have always said, and I've always read, person first, that thing.
Mm-hmm.
And you are person first, you are not defined. But I'm getting the sense that you're talking about certainly verbal people, people who are high functioning on the autism spectrum. Would that be correct?
So some of the sources that I've looked at are not by what would be called high functioning or verbal people. So some of the blogs are written by people who are nonverbal, but who can type or who can use some kind of device to
so
type.
they have language.
Yeah, well, some of them, like one thing that I looked at was by someone who had to take several days to manage to get, a paragraph of type through like a very kind of laborious purpose. So this is someone who's considered nonverbal and not to really use language very much at all, like at a rate of like one character every few hours or something like that. So even people who are as nonverbal as that are part of this community, and as far as I can tell, mostly are on board with the kind of things that I'm reporting. But I think also just the adults and children, those two groups might disagree, and children with autism I think is maybe more common because it's the parents deciding, not the children. And so there's sort of a split between autistic adults and children with autism. Yeah.
I'm an educator. In terms of children's mental health, and children's mental health leads to adults' mental health, I'm concerned that the amount of time that they spend on computers, both at home and at school, is leading to the many things that we hear about, the childhood obesity, maybe lack of ability to keep attention on something for long enough. And also you hear about social skills being lacking. Are we creating a race of people that are going to all be somewhat mentally ill due to excessive use of computers?
That's a good question.
There are studies, right? Are we not paying attention to our own studies?
My kids don't watch TV or look at screens, almost never. So I'm,
That's
you know,
very
I'm
different though than that.
I'm with you on that. Sorry?
How old are they?
7 and 2.
Yeah, you still have control.
Yeah, we'll see how long it lasts, but getting to 7 is already unusual. Yeah, but I mean, maybe I'm turning them into weird kids who aren't going to be with it. You know, who knows? And I've already started to feel like I just don't entirely know how to function in sort of digital communities, and I'm not all that old yet. So what is considered normal and what's
I think they
considered
have done studies
not
that-
normal might be changing.
Well, a lot of kids spend many hours a day, and especially as they get into their teens. I think they have done the studies that showed, you know, at over X number of hours, and
Yeah.
you begin to lose the ability to socialize, to look people in the eye, and so on. So
Yeah. Yeah, well, they have a different way of socializing on Snapchat or whatever it is that they use. Yeah. And maybe that works too. I don't, yeah. I agree, but I don't know. Yeah.
What about chemical imbalance? Did that ever, was that ever studied, or can you relate that to your?
Yeah, so what I've seen about chemical imbalance is that it's thought to be sort of too vague to be really a very useful idea, and then it implies that you can just give someone a drug and put them back into balance, when like autism is a developmental disorder, so you can't sort of just restructure their whole brain by putting different chemicals in there. It's a little bit more complicated than that. So my impression is that people have sort of stopped talking about that as much as they used to, because it's just kind of too vague and simple to really be very helpful. Yeah, but I think that's describing just the shift from predominantly using talk therapy to predominantly using drugs to treat psychiatric disorders, that while that kind of transition was happening, people were using chemical imbalance as sort of a shorthand explanation for, you know, why we could make this kind of change. And it hasn't necessarily been entirely a good thing. Mm-hmm.
You started by talking about the dichotomy of mind and body, and then from that you concluded that there are certain attitudes are a product of that dichotomy. Well, did you look, or have you looked at the history of mind-body? Is this a fairly recent perception, or has it existed for hundreds or thousands of years?
I've only looked a little bit into the history of that idea, but it's certainly a very old idea, but it's sort of come and gone a little bit in popularity. So thousands of years ago, there was already, like in Aristotle, there's spirit and matter, and these are different things. So it's old. All right. Looks like we've exhausted our questions. Thanks for coming.
Thank you.